So I'm going to be talking about electronic health records and mental health and substance use disorder care and privacy, the intersection of those, and the implications of the world we're in now with this for a learning healthcare system. A learning healthcare system, for those who don't know, is really our aspiration to take the information that we have, like so much biomedical information that's increasingly in electronic format and that was generated in the care of patients often, but to be able to use that so we can deliver better care to patients. And I would very much like for our patients, the population that we're interested in, to be able to join the rest of many other patient populations in these gains. And now I'm going to figure out how to do this. Oh, that's my pointer, my clicker. This is where it's a little embarrassing to be Chief Medical Information Officer and struggle with this stuff. Okay, thank you. So there are several barriers to a learning healthcare system for individuals with mental health and substance use disorders. One is that there's inadequate representation of these conditions in electronic health record terminologies. And we know that electronic health record adoption has not been robust in mental health and substance use disorder care as in general medical care. There are a variety of reasons for this. One is that behavioral health providers were left behind in the HITECH Act. That was the federal government incentivizing program for electronic health record adoption across the hospital. Across the U.S. in hospitals and also for ambulatory providers. And there's been a fair amount of research now that shows that it was in fact very effective, but we were left behind. Also, we face a different privacy regulatory landscape, and certainly our patients have privacy preferences of how their health information should be shared in electronic health records. And electronic health records really are limited in their ability to accommodate this, which I'll talk about more in a moment. It's really these latter two bullets that I'm going to be focusing on in my talk today. There's really two big buckets, conceptually that I put this in. One is that the way that privacy really makes things challenging for the work we're trying to do is around adoption of electronic health records in behavioral health care, that is getting the information in an electronic and digitized format. And the other is how patients would their preferences around the sharing of their health information. So that is, once you have the information electronic health record, then what should we be doing with this information to respect patient privacy? I have to give you a brief primer. Was there a thumbs up? Awesome, thanks. I have to give you a brief primer on federal and state privacy laws because they really have a big impact on this. Federal laws are considered the floor of privacy, meaning you have to at least meet the standard. States can augment the federal law or laws, and often they do for mental health and substance use disorder care. For mental health privacy, the federal law that's where we need to pay attention is HIPAA. And HIPAA does not consider mental health privacy any different than general health privacy or health information privacy. However, for substance use disorders, there's 42 CFR Part 2, the Federal Substance Use Disorder Privacy Law. That was enacted in 1987. It has very strict restrictions on how addiction treatment information can be shared for providers who are either specialty addiction providers and who are federally funded. But most providers are federally funded because, or at least providers who accept Medicare patients or have a DEA number. And so really many providers who are specialty addiction providers, most of them are covered in this. A primary care doctor who treats addiction as well as 100 other things, that information, that provider is not covered under Part 2. It's the specialty programs that are. And the regulations for Part 2 were updated in March 2017. Part 2 has been really criticized as being a real challenge for electronic health record adoption in addiction programs. And it was hoped that the updated regulations would make things easier. Some things are a little bit easier for electronic health record adoption with the new regs, but there's still many barriers. One clear win is that it's now easier to obtain Part 2 covered health information data for research purposes. So that was a welcome change. So the implications of this are that it's really harder to adopt electronic health records in behavioral health care. And it's because EHRs have limited ability to segment data, to tag it as more sensitive or not, to allow patients to have granular control. I'd like to share this kind of information broadly, or maybe just with this provider, but not that provider. And they're also limited in their ability to prohibit redisclosure of data, which is particularly important requirement for Part 2. And so, then if clinical information is not in the electronic health record, then it's certainly not available for research. And this is the graphic that I went through all the trouble of wanting to get in the slide, because the picture paints 1,000 words. These are a little bit outdated, these data from October 2013, but this is what the landscape looked like in terms of, because remember I talked about state laws, and they can also, states often do augment the privacy requirements. So this is just for Part 2 covered information, and you can see that the sea of, I don't know, what looks like, yeah, turquoise here, baby blue, that those are states that had stricter addiction privacy laws than Part 2 as of 2013. The darker blue or purple was those states were the same, and then there was less stricter, et cetera. But you can see a couple of things. One is that, Part 2 certainly has a lot of influence, but there are states with stricter, and now that Part 2 has been updated, and I don't know how quickly the states have followed along. For example, when Part 2 was updated, we received guidance in Massachusetts, now Massachusetts law, which used to be the same as Part 2, the federal law now, hadn't changed, and so it didn't really matter that the regulations were updated. And this, like beautiful graphic that I really enjoy, unfortunately I can't show you one for the mental health state privacy laws because it doesn't exist. Various kind of, policy and legal documents that I've looked at have, sort of all converged on, gosh, it's just really impossible because those laws at the state level are buried in a variety of different statutes and licensing requirements and things like that. So we don't really know what this landscape looks for mental health, except we know that it probably looks even more patchwork and even harder. So for folks who, really put their sort of the goal of focus about like how do we change the federal privacy laws, that's not really the end of the battle if that's the goal, is to how do we have harmony in these things. That really there's a lot of work that really is influential at the state level. And it all just really means that it's that much harder to meet the regulations because there's a patchwork and they're more strict than at the federal level. So now I'm going to switch gears a bit and talk about, well, what do we know about patients' preferences around privacy with electronic health records? I'm going to talk a little bit about it in general, about how studies about how patients would like their health information shared for clinical purposes and then bring it to research as well. I think it's important to talk about the broader context because it informs the research context as well. And there have been some national surveys done, sponsored by the Office of the National Health Coordinator for Health Information Technology, asking respondents about, how worried are they about the privacy and security of their medical records. And the proportion who are worried has come down, the most recent data from 2015, but it's still more than half of the respondents said that they're concerned about medical record privacy. This was independent of an electronic record or not, just medical record privacy in general. And 10% of the respondents said that they would withhold or did withhold information if their provider had an electronic health record, whereas 6% said they did the same if it were paper records. So I think there is some little bit heightened concern for patients about electronic records and the implications for privacy. And we know from other literature also in this area that patients who have sensitive health conditions, of which mental health and substance use disorders are, one of several, that they have in particular concerns about sharing of their information, and a substantial minority would restrict information from even their providers for clinical care if they could, and few would do so in a granular way. So this was a study done actually out of New Zealand and Australia. I apologize, I had a better graphic in the later slide diagram, that was a little easier to understand. But these top bars that I've highlighted in red, they ask people, how do you feel about sharing sensitive health information? Now, they didn't ask the people whether they had sensitive health conditions, but in general, how would you feel about the sharing of sensitive health information, say, with your doctor or practice nurse, ER personnel, or hospitalist? And the black bars are people who said, yes, I'm fine with that. The box bars are people who said, maybe, and then the white are no. And so you see the general, response rates that it went as high as about 70%, say, for PCP practices, down to like 35-ish%, in the hospital. If you pause and think for a moment, like some of these rates probably aren't really good for quality care, right? Like hospitalists need to know, sort of someone's health history. But, that's another that's another, I think, sticky wicket in all of this, is that patients don't necessarily understand the importance of sharing health information or in what ways it's important and helpful. But way down here, now if you look at the second bar, this is how they feel about researchers seeing their health information. You can see we're not so high on the list here, like they're not so enthusiastic. This was another study, very small sample size, and these were 21 patients with sensitive health conditions, they did this card sorting kind of test where they said, okay, here's a set of types of providers, one on each card. Here's a set of sensitive kind of health information like diagnosis, say behavioral health diagnoses or HIV diagnosis or domestic violence problems. And they asked these individuals with sensitive health conditions, how would you feel about the sharing of this information? On the left side are with primary care providers, and the yellow bar is less sensitive kind of health information. The blue bar is highly sensitive items. And on the right side are how do they feel about sharing it with researchers. Again, even though this was a very small sample size, it was about 10%, which was really about the same number in the New Zealand-Australia study I showed you, which was about 200 people. So pretty consistent, at least proportions. And like as in the other study too, you could see interestingly, people maybe wouldn't share with primary care as much as perhaps they should, for their health benefit. But we're certainly way lower on their preference list of information sharing. Oh, there's that. So, I think that this really brings up some important ethical considerations for using health information for research that we really need to think about. I've really focused on electronic health data or electronic healthcare data, but there's, as we've been talking about, there's all sorts of now different kinds of data that have privacy implications, or the combination of, say, electronic health record information with other kinds of data sources that really have important privacy implications. And I think it's important for us to keep in mind that patients do have preferences about how their health information is shared in general, and that research has shown that patients who have sensitive health conditions often more so have concerns than patients without sensitive health conditions. And these are all the people that we're looking to help study and help benefit from this research. And it's also important to consider that a minority want their health information used for research. So I think this brings up really important questions that we need to have more conversation about what's the role of patient autonomy and informed consent, and how their health information is shared for research. And really first begin to think about best practice models to consider, both in terms of how do we engage patients in understanding more about how their health information could be shared, why they might want to share it for research purposes, and also models for how do we protect patient privacy. There is an increasingly rich research literature that's looking at this question of how do we protect privacy, but also allow for a learning healthcare system. And although, this is this is a hot topic in health informatics in general, but it certainly has particular implications for our populations, our patients, who often feel stigmatized by their conditions and have a heightened sensitivity. So I look forward to joining with you all and helping to sort through, some of these really thorny, important issues. And I look forward to also as a field that we really begin to tackle them. I think that there is often a bit of a paternalism, around how we view some of this. And I think in a lot of other kinds of large database research, that there's been, sort of a, well, if it's really hard to get patient consent because it's been retrospective, or because maybe the patients wouldn't consent, and we've all seen, and some of us have done research that really we've kind of relied on those, in terms of our protocols. But I really encourage and invite us all, including myself, to rethink some of this and to really think about how can we partner with patients in this. Anyway, thanks so much for your time, and look forward to the conversation.